Welcome back to Mysteries of Health Under a Lens. If you are new here, I am a doctor currently completing my residency in pathology, and my goal is to help you understand what's happening at the microscopic level. Just a quick disclaimer before we begin. This video is a professional medical review intended strictly for residency preparation, lab analysis, and objective diagnostic education. I will be focusing purely on the high yield biopsy findings and underlying disease mechanisms rather than clinical management or treatment protocols. Please do not use this information as a replacement for medical advice. Today, we are going to break down histopathology, cytology, and hematology cases for exam going MD pathology students. Alright, then, let's get started.
1 minute, it is slightly okay. So all the participants, all the three participants, Dr. Jasleen, Dr. Ekta, and of course, very simple to say, Dr. Protest. I'm sure you've gone through all the cases. So let us first go to case 1. 20-year-old male, bilateral lower limb weakness with pain and urinary incontinence since 3 months, and MRI is showing an enhancing, as you can see, the arrow is pointing, it's showing an enhancing soft tissue lesion in the spinal canal from D12 to L2 level, more on the right side, and it is intradural and extramedullary lesion, probably neural in origin. So, Dr. Jasleen, can you just describe the slide, what you have seen? Give a brief description, yes.
Ma'am, in the sections examined, we can see tumor cells which are arranged in nests or in cords or in trabecular pattern, which are surrounded by fibroconnective tissue and embedded in a neural matrix.
Okay, embedded in a neural matrix. Okay, so then anything else? Any other feature? Have you any other feature on morphology that you've been able to appreciate? So you are saying there are nests of these cells, yes, nests and trabeculae of cells, and they are embedded in a neural matrix. Anything else? Okay, looking at the yeah, Dr. Jasleen, yes.
Congested blood vessels are also seen. I couldn't find necrosis or any mitosis here.
Okay, so you couldn't see necrosis and you can see congested vessels. Dr. Ekta, would you like to add anything?
Yes, multiple dilated and congested blood vessels are also seen.
Okay. Anything else? And Dr. Protest, can you anything else you want to add? You want to add anything else? Okay, now, then tell me something. If you look now, the laser pointer is going, you can see these cells. What is the color of these cells? These nests or cords or whatever.
Big Rai, unmute yourself. I requested you do not mute, none of you to mute. If you mute, then you cannot unmute. Sorry, Dr. Charanjit, Big Rai had by mistake unmuted. Now you can call him again.
Okay, Dr. Bigroy. So, do you want to add anything else to the description?
No, ma'am.
Okay, now look at the cells. What is the color of these cells?
Blue,
you can see these.
Dark blue.
Yes, ma'am. Blue.
Yes, so they are blue cells.
Blue cells.
Aren't these areas blue in color?
Yes, ma'am.
If you see, they are all blue in color. Okay, age is a child. Okay, and these are all blue colored, whatever you say, they are nests of cells, there are cords of cells, they are blue in color, and they are surrounded by a lot of stromal tissue, which you feel at places, yes, fibrillary, so you feel it is neural, so it is surrounded by stromal tissue, and there are congested vessels. So basically there are, what you say, we say there are blue cells. Then IHC was also given to you. So what is your result on IHC? So what have you seen on it? So these are blue cells and they are present in a stroma, as you said, which is fibrillary. So what are your differentials? What differentials would you like to keep in mind based just on morphology? Dr. Jasleen?
Ma'am, it can be neuroblastoma or
Okay.
desmoplastic small blue round cell tumor.
Or
Can be Ewing's
Ewing's.
or
Okay.
Ewing-like sarcoma.
Or Ewing's-like sarcoma. Okay, very good. Okay, now tell me, first, your option you have given neuroblastoma. Okay, now would you get such abundant? Okay, can you describe how neuroblastoma looks like? Can you give me just a quick description of how neuroblastoma, if you see a section of a slide of a neuroblastoma, what are the features that you would see?
Ma'am, those are also small blue round cell tumor, but
Yes,
we see
so it's a
rosettes
small blue
there.
round cell tumor. Okay, then?
Rosettes, we can see rosettes also in neuroblastoma.
You can see rosettes also.
We
Okay. Okay, so you can see rosettes also. What is the name of those rosettes? They have a name, no? What are they called?
Homerite.
Okay, Homerite rosettes. Anything else in a neuroblastoma? Okay, so it's a small blue round cell tumor. You can see rosetting also. But do you see such abundant stromal tissue in a neuroblastoma?
No.
Okay, no. Okay, so any other version of a neuroblastoma, you thought this is all neural matrix surrounding these blue cells, and any other feature that you are seeing in these blue cells? So they are blue colored cells. Anything else? Can you appreciate the morphology of these blue cells? Dr. Jasleen, can you appreciate the morphology?
No, ma'am, not really.
Not really. So what are they showing? What type of artifact are these cells showing? Dr. Protest, what is the artifact that these cells are showing? Or Dr. Ekta, if you want to answer.
Ma'am, smudging artifact.
Smudging, or yes, so crush artifact. So they are showing marked crush artifact. Okay, so you have these nests and cords of blue cells showing marked crush artifact surrounded by lots and lots of stroma. You don't see such abundant stroma in a neuroblastoma. Okay, Dr. Ekta, can you tell me the second differential that you would consider?
Small round blue cell desmoplastic tumor.
Okay, desmoplastic small round blue cell tumor. Okay.
Mm.
So in a desmoplastic small round blue cell tumor, what is the very, very characteristic morphology that you see?
Ma'am, abundant stroma with showing this desmoplastic reaction.
Desmoplastic reaction surrounding the blue cell nests. Yes. So the two features, characteristic features are you have blue cell nests, and surrounding the blue cells nest, you have abundant desmoplastic stroma. Okay, Dr. Protest, what is the third DD that you would think of? Third differential, just on morphology, what would you think of?
Neurofibroma.
Okay, neurofibroma. Well, how do you account for these blue cells in a neurofibroma? These blue colored cells showing crush artifact. You don't get this type of cells in a neurofibroma. Anything else? Dr. Jasleen had told another differential. What was that? Ewing-like tumor, and she had also mentioned Ewing's, isn't it? So Ewing's. So anything in favor of Ewing's in this morphology that you are seeing? Dr. Ekta or Dr. Jasleen?
I mean, Ewing's we also see rosettes. There are no rosettes present here.
Okay, so there are no rosettes. 1, 2.
Ma'am,
the abundant stroma isn't seen there.
Yeah, isn't there in Ewing's? Yes, abundant stroma isn't there in Ewing's, and abundant stroma isn't there in Ewing's-like tumors also, the other undifferentiated sarcomas. Okay, number 3, in Ewing's, you see, of course, here cell morphology is not very discernible due to marked crush artifact. But in Ewing's, what type of arrangement of cells do you have?
Ma'am, sheet or nest like?
Sheets, yes, sheets and nests of cells will be there, and you won't have so much of stroma around them. Okay, and then how many types of cells do you see in Ewing's?
Ma'am, majority of the cells are small round blue cells, and this other population is of
yes, other population is of, absolutely correct. Other population is of You have slightly larger cells also with vacuolated cytoplasm, isn't
Yes,
it?
ma'am.
So you have
Yes,
two
ma'am.
population of cells. Okay.
Mm.
So with this, you have given me the differentials. You have told it could be a neuroblastoma, which I would place later. Second, you said desmoplastic small round cell tumor, which we can place first, and then Ewing's and other Ewing's like sarcoma. So absolutely on the dot. Now we are going to do IHC. Okay. Now what Dr. Protest, I'm using that name. It's very interesting. So tell me, what IHC panel would you advise now? क्या IHC panel आप बोलोगे करने के लिए, आप order करोगे? What IHC panel will you order?
Dr. Charanjit, his other name is equally beautiful. Big Rai.
Yeah. Big Rai. Okay.
Big Rai. Yeah.
Okay. Big Rai. I think Big Rai. Okay. Big Rai. What other? What IHC panel will you order? Dr. Big Rai.
I have no idea actually.
Okay. What are you? Okay. Dr. Jasleen, you want to tell me what IHC panel you would order? Dr. Jasleen or Dr.
Or synaptophysin chromogranin.
Okay.
For
So,
neural differentiation.
okay, for neural differentiation, okay, synaptophysin and chromogranin, which would go in favor of a neuroblastoma, yes, then good. Or
Ma'am, if we get Desmin positivity or WT1 positivity, it can go in favor of desmoplastic small round cell tumor.
yes, very good. So that you would order, okay. And if you want to rule out Ewing's, what would you like to do in addition? If you want to rule out
FLI1, FLI1.
Okay, so EWS R1, FL Fly1. Okay, okay, so that is what? Okay, so the EWS R1 Fly1, of course, will not be Fly1 IHC can be done, but EWS Fly1, you will do rearrangement by other techniques. So, okay, in this case now, WT1 was done. So you can see WT1 is positive in the tumor cells. And when I circulated this case to you, I did not write C terminus. I've written that now. So can anyone tell me why? Dr. Ekta or Dr. Bigrai or Dr. Jasleen, can anyone tell me why? I've added this C terminus for you now. Initially, when I circulated, I just wrote WT1. Any idea?
They are positive in different C terminus and N terminus are positive in different.
Yes. Yes, they are positive in different tumors. So in this case, WT1 C terminus is positive. The tumor cells are Desmin positive, they are synaptophysin positive, and they are NKX 2.2 negative. So NKX 2.2 is very specific for Ewing's. So if you consider this profile together, all this profile, now this goes in favor of desmoplastic small round cell tumor. So this is a case of desmoplastic small round cell tumor. Okay, so the important differentials we have already seen. So you have to rule out small blue round cell tumors here, and you have Ewing's. In Ewing's you will have EWS R1 Fly1 rearrangements will be there. Then you should rule out the other undifferentiated round cell sarcomas. So cis rearranged sarcomas have to be ruled out, and sarcoma with B-core genetic alterations. And last is, of course, not in this case, mesenchymal chondrocytes. Such type of blue cells with islands of cartilage may be present in mesenchymal chondrocyte. But here in this slide, nowhere we can see cartilage. So I'm not considering this. Okay, so this is a case of desmoplastic small round cell tumor. And the characteristic feature of this tumor, which you can see, is nests of small round blue cells in a desmoplastic stroma. And the very characteristic feature, as you see, so it is showing this multi-phenotypic differentiation is there. Okay, so that is there. Any idea, Dr. Jasleen or Dr. Bigray or Dr. Ekta, what type of prognosis does this tumor have? Desmoplastic small round cell tumor का prognosis कैसा होता है? Okay, so it usually has a poor, this tumor usually has a poor prognosis. Okay, it's a high-grade tumor, it's a high-grade sarcoma, it has a very poor prognosis, and it's usually seen in children and young adults. And the common site for this tumor is not spine. So so if you, it's mostly the abdominal cavity. Okay. So this is the first case, that is desmoplastic small round cell tumor. Okay, now anyone, this is a spotter for you. So this is a spot taken from the classic textbook. So 65-year-old male with painless and rapidly growing nodule on the face. Give your diagnosis, and what is this pattern that you seen with CK20? Anyone? Dr. Jasleen, Dr. Bigrai, Dr. Ekta? Anyone? Diagnosis? Anyone? Okay. Dr. Jasleen, any diagnosis?
In the chat, people are writing.
Yeah,
basal
I'm
cell
seeing
carcinoma.
the
You
chat.
can see- Yeah, okay.
Yeah, I'm seeing the chat, just the students. Okay,
Yeah.
look at this. What do you see here? You are seeing epidermis. And then
Yes, ma'am.
beneath the epidermis, in the dermis, again, you are seeing these nests and sheets of blue cells. Okay, age of the patient is 65 years. And this is a cutaneous tumor. Okay, then look at the IHC picture. Chromogranin is positive and CK20 is showing dot-like perinuclear dot-like positivity. This is the characteristic feature of a Merkel cell carcinoma. So you get this case as spotter. So it's a primary cutaneous high-grade carcinoma, and usually seen as the age is there. It is seen in elderly people, and there are these small blue round cells are there, and the chromogranin positivity and CK20 dot-like positivity is seen. So this is a case of Merkel cell carcinoma. Okay. Now coming to the next case, case 2, 70-year-old male with anterior neck swelling more towards the left side, and thyroid mass is there. So it's in the thyroid. It's causing tracheal and vascular displacement. TIRADS 3 has been given on ultrasound. So first we have an FNAC. So and then Dr. Ekta, can you or Dr. Bigrai, can you describe the cytology here? Describe the FNAC picture.
Yes, ma'am.
Yeah, please describe.
And the stain smear shows moderate cellularity, comprising
Okay,
of
cellularity, good. Comprising of
spindle cells,
good.
arranged in loose clusters.
Yes, very good. Arranged in loose clusters. Yes. So very good. What you have told till now is absolutely correct. These are loose clusters of spindle-shaped cells. Okay. Can you, okay, the first two pictures, the A and B pictures, they are GIMSA. C and D is with stain. Can you make out the stain?
Etchy stain.
Okay, it's not etchy, it's a PAP. Okay, you can confuse it with etchy. Okay, it's PAP stain. Okay, now anything about, yes, very good. Somebody has written in the chat box, yes, it's a PAP stain. Now, can you tell me what is your comment on the nuclear morphology here? As you said, they are elongated spindle-shaped oval nuclei are there. Anything else on chromatin? Okay, so okay, if you have to write an impression in your FNAC report, what will you give the impression as? Okay, Dr. Bigre, जो आपने बोला था वही बताओ, वही impression है, उसी को impression बना दो. What will you call this as?
Spindle cell neoplasm.
Okay, so you are thinking of a spindle cell neoplasm. Okay, so you are thinking of a spindle cell neoplasm on FNAC. So can you give me the differentials for spindle cell neoplasms occurring in which you can see in thyroid? It's a thyroid lesion, so spindle cell neoplasms of thyroid. What are the differentials for spindle cell neoplasms of thyroid? Dr. Jasleen?
Anaplastic thyroid carcinoma with spindle cell
Anaplastic thyroid carcinoma may show spindle cells. Second, people are writing yes.
Hymoma can also show.
Hymoma, okay, but I'm saying it's inside the thyroid. So one is anaplastic, or which is the other thyroid cancer, the other thyroid carcinoma, which can also have spindle-shaped cells and amyloid. What is that called?
Medullary
thyroid.
Medullary.
Okay, medullary. Okay, third, can you think of anything else?
Angiosarcoma.
Which sarcoma?
Angiosarcoma.
Angiosarcoma. Okay. 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 Somebody is also calling it a granuloma. Okay. Granuloma in the thyroid. Okay. Anything else? What are the other? Okay. So someone has also written as a synovial sarcoma. Yes. The monophasic synovial sarcoma. Monophasic synovial sarcoma, where you have predominantly spindle shaped cells. Okay. Then you can think of other mesenchymal tumors also. Mesenchymal tumors can also occur in thyroid. Okay. So it's a spindle cell lesion. Okay. Now look at the gross picture. So Dr. Ekta, what are you seeing in the gross picture? What are you seeing in the gross?
Ma'am, gross, we can see well circumscribed mass,
Okay, good. Yes.
showing fleshy appearance and hemorrhagic area, few pinpoint hemorrhagic areas.
Hemorrhagic areas. Okay, 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 okay. And then in the picture B, low power view, what are you seeing? Here, what is this?
Uh,
What are you seeing here? What are these? What are
Ma'am,
these here?
Is that-
Anybody?
section.
Dr. Bigray, what are these?
Ma'am, I
Anybody?
think they are colloid.
Yes. So these are
Colloid.
thyroid follicular cells, thyroid follicles filled with colloid. So you are seeing, so this is a tumor in the thyroid. These are thyroid follicles, and now this is the tumor. Okay. And Bigray, Dr. Bigray, comment on the cellularity of this tumor. Any comment on the cellular? Yes.
Ma'am, it is highly cellular.
Highly cellular. So at this power, you can make out that it is highly cellular. And now tell me, Dr. Bigray, what is your comment here? What are the type of cells? Highly cellular tumor. And what are the type of cells here?
I can see spindle cells.
Okay, you can see spindle cells. Are they arranged in any particular pattern? Are they arranged in any particular? Can you make out any particular? You know, there are different patterns. Many
Ma'am,
spindles.
it
Yes.
looks like a story form pattern.
Okay, it looks like story form. Okay. Somebody in the chat box has also written syncytial. Someone have also written, use the word patternless. Okay. Okay. In this picture D, Dr. Bigray, what are you seeing? What is this? In picture D here, what is this that we are seeing?
I think it's a cyst, ma'am.
Okay, it is a cyst. Okay. Okay. Can it be anything else? One cyst. So cystic change. Can it be anything else? I can see something here. Okay, not very. Can it be? Oh, so it is a. Okay, somebody has written in the chat box. Yes, it's a blood vessel. Okay, what? It is a thin-walled blood vessel, thin-walled ectatic dilated blood vessel. Okay, so you have a spindle cell. So, Dr. Bigray, can you summarize the three important points that you told me once again? Quickly summarize them. Cellularity, bolo. What was the cellularity?
Then the section from the tissue shows high cellularity.
1, 2.
With comprising of spindle cells with
Arranged in a particular pattern or patternless?
patternless.
Pattern.
Okay, good. Patternless pattern. And then what else are you seeing here?
Thin wall blood vessel.
Thin-walled ectatic blood vessel is there.
Ectatic blood vessel.
Thin-walled blood vessel. So now what differentials would you like to keep? You people have already told you. And what IHC? Okay, Dr. Jasleen, Dr. Ekta. Okay, Dr. Ekta, what differential and what IHC? Tell me. What differential and what IHC?
Ma'am, seeing the morphology of the cells and blood vessels, we are more towards the soft tissue tumor.
Okay, good. So mesenchymal tumor 1, 2.
Mesenchymal tumor.
Okay, 2. Which
And
mesenchymal tumor?
ma'am, since it's patternless pattern,
Yeah.
this
Bolo, आप you are going in the right direction.
ma'am, this
Acha, okay, which IHC will you order to confirm your diagnosis? What IHC would you like to order?
Ma'am, CD34, since many blood vessels are there.
Okay, anyway, they are going to come positive. Anything else?
And for
so chalo,
ma'am, to differentiate between whether these cells are of thyroid origin or mesenchymal, we should order this TTF1.
Okay, TTF1.
And
Initially, TTF1. Okay, you also talked about anaplastic and medullary carcinoma. So
yes, ma'am.
medullary, what would you like to do? Yes, people are writing in the chat box, and that is correct. For medullary, what would you like to do? To rule out medullary, what would you like to do?
Serum calcitonin and
IHC भी तो कर सकते हैं ना calcitonin
yes,
की,
ma'am.
है ना?
Yes, ma'am.
ठीक है. और TTF1, okay, thyroid origin would be TTF1, and for medullary calcitonin. Then if it is not a thyroid, thyroid carcinoma or not a thyroid tumor, what other IHC would you advise?
Ma'am,
So, हाँ.
Desmin and
डेस्मिन किस लिए? डेस्मिन से अगर डेस्मिन पॉजिटिव आ जाता है, किसके फेवर में जाता है?
ma'am, more of mesenchymal and
Which mesenchymal? What mesenchymal?
soft tissue, this smooth muscles.
Smooth muscle. Okay, smooth muscle. Okay, so smooth muscle actin would go more in favor of a smooth muscle tumor. So smooth muscle tumors like leiomyomas. Okay, then what else? What else? What other IHC would you like to advise? So SMA किया, SMA नेगेटिव आ गया, ठीक है. और क्या एडवाइस करोगे? और क्या एडवाइस करोगे? Okay, somebody has written in the chat box CD117. Okay, okay. So now important differentials. So let me just quickly go through differentials. One is medullary carcinoma, as you people rightly pointed out, and then other mesenchymal neoplasms. Okay, now one more thing you remember. Sometimes we have Riedel's thyroiditis. In Riedel's thyroiditis also, there is a lot of fibrous tissue, which can even infiltrate into the surrounding tissue. But then Riedel's thyroiditis will present in a different manner. It will not present like a gross picture that I have shown you here. Now in mesenchymal tumors, you can have peripheral nerve sheath tumors like schwannomas, neurofibromas. Here the IHC, to rule these tumors out, you would do an S100. These tumors are going to be S100 positive. Then smooth muscle tumors, you will have fascicular pattern, spindle-shaped cells with blunt-ended nuclei. Here they will be positive for smooth muscle actin and desmin. Okay, then we have something called patternless and staghorn or ectatic vessels. That is a feature of solitary fibrous tumor. So solitary, then others are something called as settle fibromatosis and monophasial synovial sarcoma. Also, these are the IHCs that we have. So what you have, fibromatosis, you know, you have a very characteristic morphology. You have long sweeping fascicles. You don't have staghorn vessels. And can you suggest, any of you three, can you suggest what IHC can be done for fibromatosis? What characteristic IHC can be done for fibromatosis if we think of this diagnosis as fibromatosis? Okay, so somebody has written in the chat box, very good, it's beta-catenin. Okay, so now this is a, yes, beta-catenin, absolutely correct. So now this is a case of solitary fibrous tumor. So here we did IHC was also done. It is CD34 positive, as you people told in the beginning, BCL2 positive, and very important marker is STAT6. And this case is calcitonin negative. So you have ruled out medullary carcinoma. STAT6 is a marker for solitary fibrous tumor. So STAT6 is positive. In addition, CD34 and BCL2 are also positive. So this is a case of solitary fibrous tumor. And जो characteristic morphology आपने बताई थी, you get that. You have haphazardly arranged spindle to ovoid cells. You have these staghorn vessels. And the characteristic molecular abnormality is NAB2 STAT6 fusion gene is seen. And STAT6, of course, is positive. 34 is positive, and then other markers can also be positive. Okay, so this is a case of solitary fibrous tumor of thyroid. Okay, now next spotter. Can anyone identify? Spot the diagnosis, 44-year-old woman with thyroid nodule. You can see the gross morphology. Then look at the HE slide, and then TTF1 and MIB1 has been done. Anybody? Anybody? Okay, so many people have written in the chat box, and that is correct. So good. Many of you have written in the chat box, and that's correct. So, okay. Anybody, three of you, Jasleen or Big Ray or Ekta, any of you? What is this? Okay, so now that was a mesenchymal tumor. Now this is a tumor that arises from the follicular cells of thyroid. So this is a hyalinizing trabecular tumor. Okay, so this is a hyalinizing trabecular tumor. Okay, look at this. Characteristic morphology, you have these nests, cords, or trabeculae. The tumor cells will be arranged. Then second, there is a lot of this pink material which you can see. This is hyalinized. It's called hyalinizing trabecular tumor. So you will see hyalinization. This pink material which you see is hyalinization. Trabeculae, you have these trabeculae and nests which are separated by these blood vessels here. 2 and 3, there is very characteristic nuclear features. You know, they are, I've not shown you, they are like PTC. They are like papillary. You will see grooving, you will see inclusions, and you will see some yellow bodies. Okay, second very characteristic feature, it's arising from thyroid, from follicular cells. You can see TTF1 positive, and somebody has written in the chat box, this is the only tumor, remember, where MIB1 kya hota hai? Ki67. Here Ki67 shows membranous staining. Normally, where do you see Ki67? It's always in the nucleus. MIB1 or Ki67 shows nuclear staining. Here it is showing membranous. So this is hyalinizing trabecular tumor, which is usually a benign tumor of thyroid. Okay, so this is the spotter that you have. Okay, now let us see, coming to the next case. Okay, case 3, 44-year-old male, rapidly enlarging mass in the right breast, located in the upper outer quadrant, 6 by 5 centimeter. No nipple areola normal, no skin dimpling, or no axillary lymphadenopathy. Okay, Dr. Ekta, will you describe this for me?
Yes,
Describe
ma'am.
the sign, please.
Yes, ma'am. Section examined show a highly cellular tumor,
Okay.
spindle cells comprising of
Composed of
spindle cells.
Any
Um,
arrangement?
Yes,
Any arrangement?
ma'am.
Okay, what arrangement? So you
Sweeping
are
fascicles.
okay. There are fascicles. Okay,
Yes,
good.
ma'am.
Then
Uh,
look at these pictures now.
yes, ma'am.
Okay. So next, higher power view. What are you seeing?
Ma'am, on high power view, we can appreciate there are few binucleated and multinucleated cells
Okay.
are also noted.
Multinucleated cells are there. Okay. Any comment on pleomorphism? Is it
Yes, ma'am.
okay?
Marked pleomorphism is seen.
Okay, marked pleomorphism is seen. Good.
With prominent nucleoli.
Okay,
And
prominent nucleoli at places, marked
yes,
pleomorphism.
ma'am.
Okay.
And moderate to abundant eosinophilic cytoplasm.
Okay, so there is cytoplasm, yes. And the cells, so there is pleomorphism, they are varying in shapes and sizes. Nuclei
yes, ma'am.
also look high grade, tumor giant cells are there. Okay,
Yes,
next
ma'am.
picture, anything else in these pictures? In this picture, both these pictures, which now I have pointed with black, what else are you seeing? What else are you seeing?
This is no desmoplastic reaction.
Desmoplastic nahi. Dr. Bigre, any idea? What is this? What we are seeing here? Okay. Anybody? Okay, so in this picture, okay, see, this is pink colored material here. Okay,
Yes,
somebody
ma'am.
has written heterologous elements. Yes, Dr. Gunjan, very good. This looks like osteoid here, and this area focus, which is there are slightly chondroid areas are also there. And the pink material here, which you see here also, and in this picture, this looks like osteoid. So in this picture, it is there in many places. You can see my arrow is, the laser pointer is pointing here. You can see these cells surrounding them. There is this pink material, which is being deposited, amorphous pink material. This is osteoid. Okay, so now this is a spindle cell tumor. Okay, so good people are answering in the chat box. Okay, so this is a tumor wherein you have, as you described, morphology cellular hai, spindle cells hai. At places, it looks like there are fascicles. You are seeing marked pleomorphism. You are seeing cartilaginous areas, and you are seeing osteoid also. So now, Dr. Jasleen, your differentials, please.
Ma'am, it could be malignant phyllodes or metaplastic carcinoma.
Okay, so number one, okay, good. Malignant phyllodes with, so yes, malignant phyllodes with
Heterologous
Heterologous element. So what heterologous are you seeing? What heterologous element are you seeing?
Osteoid and chondroid differentiation.
Okay, osteoid, and so probably with osteosarcomatous differentiation. So that's the heterologous element here, isn't it? Very important is if you are seeing osteoid, that means it's an osteosarcomatous differentiation if you are seeing osteoid. Okay, second differential, Dr. Jasleen, which you said was correct. What is the second differential?
Metaplastic carcinoma.
Okay. So very good, metaplastic carcinoma. But in metaplastic carcinoma, in addition to this, what else will you see? It's a metaplastic carcinoma. So you can see these features. What else will you see? To call it a metaplastic carcinoma, what else will you see?
It might show squamous.
Yes, so no, it will show epithelial. You will see epithelial, malignant epithelial cells also, no? So you will see both epithelial cells and you will see these metaplastic elements also. Okay, and third, can you think of anything else? Okay, now let me tell you, for everybody who is writing, giving correct answers in the chat box, let me tell you, number one, extensive sampling was done in this tumor and there were no phylloid-like areas. So, Dr. Bigre, phylloid-like areas kaise hote hain? Can you describe a phylloid-like area? Phyllodes tumor mein what type of areas do you get?
We can see the leaf-like pattern.
Very good. So you see leaf-like areas, stroma, leaf-like stroma, yes, leaf-like pattern. So we did extensive sampling of this tumor. There were no leaf-like areas. Okay, point number one. Number two, there was no epithelial tissue, no carcinoma element at all in this tumor. So now, if there is no phylloid-like areas are not there, to call a tumor as malignant tumor with the heterologous osteosarcomatous differentiation, you should have phylloid-like areas. You have to document them somewhere. Second, to call it a metaplastic carcinoma, you have to get carcinoma component. Okay, now can you think of a third differential? So, जो आप लोगों ने बताया बिल्कुल correct है. The approach to this case is like this only. Okay, so now can you think of a third differential now? I have told you no phylloid-like areas. I have told you there is no carcinoma component. So can you think of a third differential? Just a pure sarcoma. So primary sarcoma, yes. So with sarcoma now, which is the sarcoma that is going to produce, where the sarcoma cells are producing osteoid? What is that sarcoma called? जो sarcoma osteoid बनाता है उसको क्या कहते हैं? ये तो definition. It is called osteosarcoma. Osteosarcoma. Okay. अब मैं बोलती हूँ कि breast में osteosarcoma है. कहाँ से आ सकता है osteosarcoma breast में? Very rare. From where can it come? From where can it arise?
From ribs.
From bone.
Ribs.
Yes. From ribs. Okay. Underlying bone 1, 2. Somebody put in the chat box. Rightly put in the chat box. They said metastasis. Okay, osteosarcoma elsewhere, metastasis. And third, there is no osteosarcoma elsewhere. All the bones are okay. The underlying ribs are absolutely normal. Can we still have an osteosarcoma? So there are no mets. Yes. So can we still have an osteosarcoma? Yes, people have written in the chat box. Absolutely correct. So there is something called as extraskeletal or extraosseous osteosarcoma also. So now in this case, if we see, so metaplastic carcinoma, all these are your differentials. Absolutely correct what you have given. Metaplastic, malignant phyllodes with heterologous osteosarcomatous elements, or it could be primary or extraskeletal osteosarcoma. So that is the diagnosis, because in this case, the underlying bone was absolutely normal. There was no metastasis here. The patient was not a known case of not a known case and of osteosarcoma elsewhere. There was no carcinomatous component, so a diagnosis of primary osteosarcoma was made. And usually this is very rare, but 5 to 10% may be associated with previous radiation. Okay, osteosarcoma ka marker aap sab yaad rakhna, SAT-B2 is the marker. Okay, now coming to the next case is a spotter. Quickly, we have to finish. We have 2 more cases. Okay, so 13-year-old female presents with pain in the right leg. X-ray shows well-defined lucent lesion in the right lower femur. What is the diagnosis here, spotter?
Giant cell tumor.
Okay, one giant cell tumor. Okay, look at the second picture. What are you seeing in the second picture? Okay, one giant cell tumor, but look at that second picture. That is giving away the diagnosis. Yes, people are writing in the chat box. That's correct. Okay, what are you seeing here? You are seeing these giant cells, osteoclastic giant cells, and you are seeing these chondroblasts here. And this is chicken wire calcification. Okay, yes, so this is an osteoblastoma. Okay, so it's a, sorry, it's a chondroblastoma.
Chondroblastoma.
Yeah, so you are seeing chondroblasts. You are seeing these osteoclastic giant cells in chicken wire. Okay, tell me, can you tell me a characteristic, if you see this under higher power, characteristic chondroblast की characteristic nuclear morphology में क्या दिखता है? One line just. What is the characteristic nuclear morphology of a chondroblast, which you see here in chondroblastoma? What do they show? Yes.
No. Eccentrically placed nucleus, like it's coming out of cytoplasm.
Oh no, you see coffee bean or nuclear grooving. जो papillary carcinoma में दिखती है ना grooving, coffee bean nuclei कितने, इसमें भी coffee bean. So coffee bean nuclei papillary carcinoma में भी मिलते हैं, chondroblastoma में भी मिलते हैं, Brenner में भी coffee bean nuclei मिलते हैं. And there may be more. I'm forgetting these three. I remember distinctly. Okay. So this is a case of chondroblastoma. Okay. So coming to the next case. Okay. 27-year-old male, progressive headache and seizure. Very important. Extraaxial mass, dural based extraaxial mass is there. And there is a mass effect on the adjacent frontal lobe accompanied by perilesional edema. Okay. Now, anyone, Dr. Ekta, can you describe these slides? What are you seeing? Dr. Ekta?
Section examined show highly cellular tumor cells, which are
one.
Yes, ma'am.
Two.
Ma'am, monomorphic population of this small round blue cells are seen.
Oh, these are
small
blue
round cells, not blue cells, ma'am. Round cells.
Okay, round cells. Okay, what else? Arrangement कैसा है? Arrangement कैसा है?
Ma'am,
what is the arrangement? How are they arranged? People have written in the chat box also. Aren't these cords? So these are cords, no? So these are cords. So they are arranged in cords.
Cord-like.
Okay, so they are arranged in cords. Okay, now remember, I have already given you, it's a dural-based tumor. In the history, we have given you, and the tumor cells are arranged in cords. Okay, and background कैसा है? ये cords में tumor cells है. तो कहीं-कहीं छोटे-छोटे nests, small nests are also there. And what is the and trabecula? And what is the background? What are you seeing in the background?
Little fibrillary background.
It is, yes, Dr. Bigre. Background कैसा है?
Myxoid.
Myxoid background, yes, myxoid or excellent myxoid or mucinous background.
Mucinous background.
Yes, myxoid or mucinous, or at places it appears mucinous. So there are cords and trabeculae of cells, and they are lying in a very mucoid-looking background. Okay, and now look at the comment on the nucleus and the cytoplasm. How much is the cytoplasm of the cells? It is
moderate.
Yeah, moderate amount. Okay.
Moderate eosinophilic
moderate amount of cytoplasm is there. Okay. So you are seeing all these pictures. Okay. Yes, people are writing in the chat box. You've even made a diagnosis. Very good. The diagnosis is correct. So you can see these cells. Okay. Now, what differentials will you keep? Dr. Bigre or Dr. Ekta or Dr. Jasleen, any one of you, what differentials will you keep?
Chordoid meningioma.
Yes, very good. So first is chordoid meningioma, since it is a dural base mass. If it was not a dural base mass, could you have thought of anything else?
Ependymoma also, since seeing the cells morphology.
Yeah. Okay. So you are saying once again, Dr. Jasleen, what did you say? I did not get it. Yes, very good. So chordoma. Okay. So chordoma के cells को क्या बोलते हैं? What is the description of those cells? Chordoma cells? What is
Physelliferous cells.
Physelliferous cells. So they are large cells with abundant vacuolated cytoplasm. They are called physelliferous cells. Yes, very good. People are writing in the chat box. Absolutely correct. Physelliferous. Okay. Third differential. If I say, okay. So if I say that it is not a dural base mass, it is in the brain parenchyma itself. Can you think of any other differential with this chordoid morphology? So this is a chordoid morphology. So always remember, chordoid morphology is it could be a this chordoid meningioma. It could be a chordoma. So you have to read your history carefully. And third, anything else? If it is in the brain, yeah. Any glioma?
Ependymoma.
Ependymoma. Okay, ependymoma. Okay, so something like a myxopapillary ependymoma. Okay, which has a very characteristic site. Okay, anything else? In a myxopapillary ependymoma, do you get cords of cells like this? Yes, you get abundant myxoid material in the background. Okay, so any other? Okay, so what IHC would you like to order? If your first diagnosis is chordoid meningioma, what is your IHC?
EMA.
EMA, okay, good. 1, 2.
EMA, podoplanin.
Podoplanin, very good. That would be positive. EMA would be positive. What about
Positive.
yeah, और कोई marker?
Ma'am, pankeratin.
Okay.
Pankeratin.
अच्छा, और कोई बताओ? Any other?
SSPR2A and progesterone receptor PR.
Progesterone receptors may be positive. और chordoma के लिए कौन सा करोगे? What one marker can rule out a chordoma? What is positive in a chordoma? Brachyury. Okay, now you please identify the special stain quickly. ये कौन सा stain है? Which is
An
the
Alcian
special
blue stain.
Yes, it is an Alcian blue stain. Okay, Alcian blue, Dr. Ekta, Alcian blue is for what does it stain? Alcian blue stain, what does it stain? What?
The mucin.
Mucin. Which type of mucins does it stain? Acidic mucin, sulfated and carboxylated. Acidic mucins are stained by
Acidic
Alcian blue.
mucins.
So this mucoid background is stained positive in a chordoid meningioma by or Alcian blue stain. So yes, everybody is written acidic. So good. So chordoma, chordoid glioma, chordoid meningioma, and then there are other differentials also like metastatic carcinoma, but it doesn't look like one, and myxoid chondrosarc. Myxoid chondrosarc will be S100 positive. Chordoma will be brachyury positive, and then you've already told me the markers for chordoid meningioma. So this is a case of chordoid meningioma, which you classify as WHO grade 2 tumor. Okay, so this is a chordoid meningioma, it's WHO grade 2, and this is the characteristic morphology, cord or trabeculae of epithelioid or spindle cells embedded in a rich mucin-rich stroma and resembling a chordoma. Okay, okay, now next identify this. So this is a spotter, 56-year-old male. So this is to help you differentiate between these two entities. So the microscope image from the sacral mass hai, and look at this staining and the HE. Okay, so what is this now? Look at these big cells here and the cords of these smaller cells which look like the chordoid meningioma cells and the other cells. So what is this?
Chordoma.
Yes, so this is a chordoma and this is nuclear positivity for brachyury. Okay, so now you can see the difference. So here we are seeing the ficelliferous cells which were not there in that slide. So very good. So this is a chordoma now. Okay, quickly going to the next case, case 5. This is the last case, 55-year-old female. I should not take much time. Okay, postmenopausal bleeding, and you have this solid cystic adnexal mass with hemorrhage. Okay, any doctor? Any one of you? Bigre, can you give a description, Dr. Bigre?
Yes, ma'am.
हाँ, जल्दी से बता दो.
Sections from the tissues shows highly cellular.
Okay, 1.
High cellularity.
Okay, 2. Yeah.
Arranged in microfollicular and macrofollicular pattern.
Pattern. Okay, good. 3.
And,
what else? What else? Higher par पे जाएं. और क्या दिख रहा है?
Nuclear grooving can be seen.
Nuclear grooving can be seen. Okay, so some of these nuclei here, this nucleus here, they are showing nuclear grooving. Okay, nuclear grooving is seen. Okay. Okay. So, and then you have to tell the description of the cells. What is the amount of cytoplasm? So a good description. Okay. So what is your diagnosis? What differentials would you keep and what IHC would you like to advise? Dr. Ekta, what differentials? Okay, so people are writing in the chat box. Yes, absolutely correct. So I think Bigre is talking about granulosa cell tumor. So yes, it's an adult granulosa cell tumor. Okay, so what differential? इसमें Karl Exner bodies इतनी prominent नहीं है. इसमें macrofollicular pattern है. They are in sheets. So what other? Can you think of anything else? Any other tumor fitting this morphology? characteristic Karl Exner bodies are not there here. Okay. There is macrofollicular pattern, yes. And there is nesting pattern also. There are tiny, there are macrofollicles, yes, they are there. These may be microfollicles, but not, okay. Second option, as somebody has written in the chat box, we will also rule out juvenile granulosa cell tumor. Okay, anything else? Acha, chalo. Now, what is the IHC that you do? Okay, so you have adult and juvenile granulosa cell tumor. Then you should also, though the morphology is not like carcinoid, but carcinoid, small cell carcinoma of ovary, hypercalcemic type, that is a high-grade tumor. You will see all features of a high-grade tumor. And of course, cellular fibroma or thecoma. But again, in fibroma, you have spindle-shaped cells. So this is last in the list. So I would like to consider at least the first three. Okay. So if you want to rule out a carcinoid, what IHC should be negative? Carcinoid.
They will apply inhibin and FOXL2 for this granulosa cell tumor here.
Very good. So inhibin and FOXL2 are positive in adult granulosa cell tumor. What about juvenile? Is FOXL2 positive in juvenile granulosa cell tumor?
No, ma'am.
No, so it is not positive. Okay. Or carcinoid के लिए क्या करोगे? Yes, people who are writing in the chat box, you are correct. Carcinoid के लिए क्या करोगे?
Phenaptophysin chromogranin.
Chromogranin.
Yes, phenaptophysin chromogranin would help you to do that. Okay. So this is a case of adult granulosa cell tumor. We already know FOXL2, SF1, most sensitive for sex cord stromal, inhibin A, calretinin. अच्छा, अब इसमें special stain याद रखना है, reticulin को याद रखना है. अगर if you want to differentiate it from fibrothecoma, you should do a reticulin. If you have confusion, reticulin, there will be in a fibrothecoma, you have pericellular staining, whereas in case of adult granulosa cell tumor, there's lack of pericellular staining. In fact, the entire nest is surrounded by the nest, or large groups of granulosa cells are surrounded by reticulin fibers and not individual cell as you see in a fibrothecoma. Okay, so that is an adult granulosa cell tumor. It shows nuclear grooves. It has these various patterns: diffuse, trabecular, cord, insular, and so on, and macrofollicular. Okay, okay. Quickly spot the diagnosis. Last slide. What is the diagnosis? 40-year-old male, seropositive. Give your diagnosis. Special stain that you will use. ये क्या दिख रहे हैं इसमें? Seropositive भी है. ये देखो. Okay, Dr. Mandeep has answered. Abhijit. Okay, good, Abhijit. Okay. Yes.
Histoplasmosis. Fungus.
Fungus. Which fungus? Okay. You said histoplasmosis. Any other fungus?
Crypto.
Acha, dekho, look at the size. Isn't it a big fungus? So
Yes,
histo is actually very small in
very
size.
small.
Okay, so this is cryptococcus. The patient is seropositive, HIV positive. So this is cryptococcus. Okay, so अब special stain क्या करोगे?
India ink.
हाँ, India ink. India ink में क्या दिखेगा? What will you see? What is the characteristic? Capsule will be, yes?
It will be stained.
Capsule will stain or it will not stain? So yes, people have written in the capsule will not stain. So negative staining with India ink. Second, which other stain will you do? Fungal stain कौन सा है और? Yes,
GMS stain.
Okay,
GMS,
GMS stain. Okay,
PATH.
so GMS and mucicarmin. So this is silver methenamine or GMS. So you can see this is negative staining with India ink. First picture where you are seeing a clear halo around the cryptococcus. This is GMS or silver methenamine stain where the fungus is highlighted black in color. And third is mucicarmin stain here. Mucicarmin will stain the capsule. The capsule is a mucoid capsule. So mucicarmin is going to stain the capsule. Okay, so this is the last slide. I have taken 5 or 8 minutes extra. Dr. Gujral, I have taken extra time. So
thank you. Thank you very much. No, it's fantabulous session. Thank you.
Okay, so I can now stop sharing my screen, and if you have any questions, we can take them after the entire session. Dr. Navjeet's session is over. So I'll stop sharing.
One is that. Second is, madam is available. You can question in the chat box.
Yeah, I'm there. Yes,
I'm the
absolutely.
chat. Yeah.
Okay, so I'll just.
Hi, Navjeet, you're there?
Yes, sir.
Hi.
I'll just stop sharing.
So after some time, quite some time, we crossed, there's still 225 students listening to you. It's 8 p.m. now, almost 8.
Yeah. So
Kept them engrossed. Thank you very much, Dr. Charanjit.
yeah.
So over to you. Students, you can take a small 2 minutes break, have a glass of water.
Yes.
And in the meantime, please. And I'm sure you all enjoyed. As we promised, it won't be difficult for you. Madam is basically, she was answering all the questions. And chat,
because
and chat was helping you so much. Even I was looking at
they
the
were
chat.
giving the right answers in the chat.
Chat was giving the right
I'm
answers.
proud of all those students. They
So
are being taught well.
I would request, don't look at the chat. Students, please don't answer or answer wrong. It's better to be wrong than to copy somebody. I'm sure you don't look at the chat. I was looking at the chat. I'm a cheater actually, but I would recommend that don't be a cheater. Enjoy. Okay, over to you, Navjeet.
Thank you, sir. What a beautiful session, ma'am. We really enjoyed it. You should have been given more time.
Hi,
Should have been a
Rajesh. I
longer
can see
session.
Rajesh.
Yes, it was really beautiful. Maza aa gaya. Okay, chalo. So, Jasleen, Bigrai, and Ekta, I hope now you're ready to shift gears and we'll move into hematology now, right? From the world of histopathology. So I'll share the cases. 1 second. Let me share my screen. Right, can you see the screen now?
Yes, sir. The screen is visible.
Great. So let's start with case 1, right? Without wasting too much time. This is a 65-year-old lady. History was headache, dizziness, and itching. And on examination, there was one spleen was seen 1 centimeter below the left cost margin. So this is the first slide that I've given you. The peripheral blood was showing this. So should we start with Dr. Jasleen? Can you tell us what you are finding here in the peripheral blood?
Yes, sir.
Hi, Jasleen, are you there?
Yes, sir. Sir,
What are the
IBC,
findings here?
so yes, sir, IBC population seems to be increased,
Right.
and they have moderate anisoperculocytosis. I can see microcytic hypochromic macrocytes as well as normocytes.
Okay.
PLC is increased. It is 18,000.
Yes.
And a metamyelocyte can be appreciated, or a myelocyte.
Right. So let me just put on my laser pointer, and this is slide that you're calling as a metamyelocyte or a myelocyte, right?
Yes, sir.
Absolutely. So we have a left shift wala cell that we have given in my differentials also, right? And you have TLC that you said rightly increased. What about the platelets?
The platelets are also
increased, right? Yeah. So we have platelets that are increased. We have a hemoglobin which is around 15.6. So 65-year-old lady again increased. What is the cell that you see here on the inset? Can you tell me what cell this is? Jasleen, are you there?
Would you like to use a pen?
Sure.
Navjeet, or the kids maybe, yeah.
Sure. Right. So this cell, Jasleen, the cell that is there in the inset, what cell is this?
It's filled with granules, but I can't appreciate it.
Anybody else? Bigrai, are you there?
Yes, please, sir.
What cell do you think this is?
Can it be basophil, sir?
Yes. Why are you saying that?
Because the nucleus is getting obscured by granules.
So there are a lot of granules. Absolutely, you're absolutely right. Yeah, there are a lot of granules, thick bluish granules. They are kind of obscuring, not really obscuring totally, but kind of obscuring these the nucleus. So you will find some basophils which are characteristically how they are described in your textbook, where we will have only dark blue basophilic granules will totally cover the cytoplasm. But oftentimes you'll also find these cells where the granules are not too many. Sometimes you'll also find slightly hypogranulated basophils also, where the granules might be a little less. So you'll have to really recognize these basophils as well, right? Right. So Bigrai, as we noted, we have increase in platelets, we have increase in TLC and hemoglobin of 15.6. We have some myelocyte, some metamyelocyte. The history was of a 65-year-old lady with a history of headache and dizziness. So what do you do now? So basically, there's hematology. Most cases, you'll get some history and peripheral blood, and then you'll have to decide what you do ahead. So what do you want to do now? Do you have any idea what we might be looking at here, and what do you want to do ahead?
We'll go for a bone marrow examination.
Bone marrow.
Bone marrow examination. Why do you want to go for a bone marrow examination? We have to be clear about that as well, right? What do you want to check when you do a bone marrow examination?
We will try to
We'll check for
PML or any myeloproliferative neoplasm.
Myeloproliferative neoplasm. So why do you think we are talking about a myeloproliferative neoplasm here?
Because everything is increased. RBCs,
It's an
WBCs, and
elderly
platelets.
female. We have
An elderly
increase.
female.
Yes. So we have increase in platelets also. We have increase in TLC also. So yes, that's absolutely right. We're also seeing basophils. Normally, you can see here in our differential, we have given 3 basophils, right? And normally the basophils in the peripheral blood should be less than 1%, right? So when we are having increased number of basophils, you start thinking towards the myeloproliferative neoplasm. Here also we have increased hemoglobin, increased platelets, increased TLC. So everything is increased. The counts are increased. We have some myelocytes and we have increased basophils. So absolutely right. We are thinking of probably a myeloproliferative neoplasm, and that's why we are going towards the bone marrow examination, right? So Dr. Ekta, now we do a bone marrow aspirate. What do you see in this slide?
A smear exam and show.
What is this thing here? You think that is just marked? I'll just circle it again. This entire thing.
That's a bone marrow particle.
That's a bone marrow particle, right? So we have a bone marrow particle. Can you try and comment on the cellularity of this bone marrow particle? There's a 65-year-old lady. What do you think the cellularity is?
The single bone marrow particle is seen in this smear.
Yes. So in this single bone marrow particle, would you want to comment on the cellularity?
So hypocellular, we can say.
Hypo. Why do you want to say it is hypo? So you see the fat, which is these white spaces, and you see the cells, which are these blue spaces, right? So what do you think is proportionately higher here? Are these blue spaces higher or the white spaces higher?
So blue spaces are higher.
Right? So the cells are more here, right?
Yes,
compared to the fat. So this looks like a hypercellular bone marrow aspirate, but always remember that bone marrow aspirate is not the good preferred specimen on which we will comment on the cellularity. It has to be the bone marrow biopsy, because bone marrow biopsy gives us a much more wider area to comment on the cellularity, right? But based on this single particle that we have here, it probably looks like a hypercellular bone marrow aspirate. Okay, so let's go ahead and let's look at this. We have say a 10x view of the bone marrow aspirate. What do you see here, Dr. Ekta?
We can see multiple megakaryocytes.
Great. And I've given you the differential also. So what do you think the differential is? Is it abnormal? Is it normal?
Sir, it's abnormal. Actually, it's.
Why do you think it's abnormal? What is the abnormality here?
You can see multiple megakaryocytes.
No, I'm talking about the differentials. The differential that I've given, right? 1 blast, 4 promylo. This.
Oh, sorry, sir.
Yeah,
the differential is.
Does this
differential is normal.
The differential looks normal, right? More or less looks normal. The MA ratio would come somewhere around 3:1, which is probably normal for the bone marrow. Yeah, we have around 15% myelocyte, 10% metamyelocytes. Looks more or less normal, the differential count here. But yes, as you rightly said, the megakaryocytes definitely look increased. What kind of a megakaryocyte is this one? The one that I'm drawing right now, Ekta?
So hyperlobated.
Right, hyperlobated, right? Absolutely. So we have some hyperlobation also that we note here. Okay, so in the next slide, I've given you some collage of these macrocytes. So can you comment on this, Dr. Ekta? What type of macrocytes are here, and what will you say about these macrocytes?
Yes, so these are first two are hyperlobated and
What
and
about this one? This one here?
hmm,
This I totally agree with you. Definitely looks hyperlobated, like a staghorn.
yes, sir.
This the second one and the third one look more or less okay-ish, normal
Yes,
kind.
sir.
And the last one that I'm now circling around, what about this?
Uh,
This does this look like a small hypolobated kind of a megakaryocyte,
yes, sir, it's small.
right? Yeah.
Okay.
Yes, so we have all kinds of megakaryocytes here, right? We have some hyperlobated ones, we have some small-sized ones, and we have some normal-sized ones also, right? So we'll call
Yes.
this as the pleomorphism that is noted in the megakaryocytes, right? Do you agree, all of you?
Yes, sir.
Great. So now that we have noted some hypercellularity, some pleomorphism, we go ahead and we go into the bone marrow biopsy. So let me ask Jasleen here. Firstly, when we have seen the bone marrow aspirate and we want to go to the bone marrow biopsy, what additional information do you want to see in the bone marrow biopsy? So what is the information that you get from the bone marrow biopsy in addition to bone marrow aspirate? Jasleen?
Sir, cellularity as well as the normal positioning of the cells.
Wonderful, right? So
And
first thing you would need to
okay.
confirm is the cellularity. We can take an estimate of the cellularity in the bone marrow aspirate, but it has always got to be confirmed in the bone marrow biopsy. And the second thing also you said very rightly that where are the cells placed? Are they placed in their normal location or not? Right? So these are the two things that you definitely want to see. Anything else?
So fibrosis can be checked after
Fibrosis.
reticular stain.
Yes, fibrosis also. Anything else not pertinent to this case, but in general, what is an advantage of a biopsy? In which particular diseases are biopsies more advantageous than aspirates?
The iron storage or any storage disorder.
Iron storage is also a good answer, but now my more specific question was, what kind of diseases are biopsies more helpful than aspirates?
The myelofibrosis.
Myelofibrosis.
Okay, and
Mm.
again, not pertaining to this case, but in general.
But in CLL, we see the mm, architecture of the cells. If it's nodular or diffuse, prognosis depends on it.
Okay, that is one thing. However, in the current era, probably the prognosis is not that much dependent on the kind of infiltration, but still, yes, that's one thing. Anything else? So again, which kind of diseases? You said CLL, so lymphomas, right? So why lymphomas? What kind of lymphomas are would be seen better in the bone marrow biopsy?
Mm.
So what I want to say is that those diseases which are not primary bone marrow diseases, right? Like acute leukemias is a primary bone marrow disease, right? So there, even the aspirate, you will have everything. But the bone marrow biopsy, the advantage of bone marrow biopsy over an aspirate is that it gives a larger view of, say, you get a 2 centimeter biopsy or a 2.5 centimeter biopsy. So you get a broader view of the entire bone marrow. Whereas when you're doing a bone marrow aspirate, you just take a needle and you put into one point and you're seeing only the cells of that particular area in which your bone marrow aspirate needle went, right? So the bone marrow biopsy will always give you a much broader picture of your bone marrow. So that is why all those disorders which have a focal infiltration of the bone marrow will always be better appreciated in a bone marrow biopsy, right? So for example, sometimes your lymphoma infiltrations, some metastasis, granulomas, all these things can be much better appreciated. Even your multiple myeloma, all these things can be much better appreciated in the bone marrow biopsy and not in the bone marrow aspirate. Whereas the bone marrow aspirate, the advantage it gives is that the cellular morphology is the best explained in the bone marrow aspirate, right? So with that, we move ahead and we go to the bone marrow biopsy. And Bigrai, what do you see in the bone marrow biopsy? First thing.
Sir, the adequacy we will have to see.
Right. Suppose, how do you define adequacy in the bone marrow biopsy?
Sir, minimum 8 intertabular space has to be present.
Okay, 8 to 10 intertabular spaces. And anything else? Length of the biopsy?
1.5 to 2 centimeter at least.
Great. So that's what WHO says, 1.5 to 2 centimeter at least in length, and 8 to 10 intertrabecular spaces to be seen. Right. So suppose this biopsy is adequate. Now what do you see in this scanner view of the biopsy? We talk about the cellularity. What is the cellularity here?
Yeah, cellularity is increased, hypercellular.
How much would you say the cellularity would be roughly?
80%.
Right? Absolutely. 80 to 90% is something that I would say. You should always give cellularity as a range, right? Because various different areas will have different kind of cellularity. But yes, absolutely, for a 65-year-old lady, now you agree that there's a hypercellular bone marrow. We thought so in the bone marrow aspirate as well, but now we are confirming in the bone marrow biopsy scanning view that this is definitely a hypercellular bone marrow, right? Then we go ahead and look at the bone marrow biopsy at a closer picture. So Bigrai, what do you see here?
So I can see the megakaryocytes is increased in number.
Definitely increased in number. And in the aspirate, where I think the morphology is not greatly appreciated here, but yes, we can see some large ones like these and some small and normal sized ones like these as well. So the pleomorphism that we noted in the aspirate is there in this, and there is definitely some clustering also that is there that you can see these 3 or 4 megakaryocytes lying together. So loose clusters are being formed here, and they are also lying close to the trabeculae. Where Bigrai, where should megakaryocytes normally be lying in the bone marrow? What is the area?
In the center, in between the intertabular space.
Absolutely. So in the interstitium, next to the sinusoids, right? That is where they should be. And why should they be next to the sinusoids? What are they doing? Why do you think these megakaryocytes should be next to the sinusoids in normal location? They're producing platelets, right? They are producing platelets, and these platelets are directly released into the circulation via these sinusoids, right? So that is why their location should be in the perisinusoidal region. But when they come near the paratrabecular region, that is an abnormal finding that we have, right? So we now see an increase in megakaryocytes. We are seeing some kind of megakaryocytic clustering as well, right? And then I'm going to the reticulin stain. Ekta, can you tell me what, how would you grade this reticulin? Do you think it is high?
No, sir.
Not really, right? So, what would you say? How is reticulin graded? From which grade to which grade do we usually do it as per WHO?
So 3 grades, grade 1, grade 2, grade 3.
So it starts from 0, right? It's 0, 1, 2, and 3, right?
Yes.
So here, what do you want to call this? Do you want to call this 0, 1, 2, or 3?
So grade 1. Okay.
Grade 1, yeah, maybe 0 to 1 is what we have here. So, okay, so now we have a lot of information about this case. So, Ekta, what do you think our diagnosis is here, or at least a differential diagnosis? Do you think we are dealing with a myeloproliferative neoplasm?
No, sir.
I'm sorry, could you be louder?
Not sure, sir.
Not sure. Okay, Jasleen?
Sir, it might be PMF.
It might be PMF.
Maybe
Okay, that's a good answer. So, do you think it's a myeloproliferative neoplasm, MPN?
Yes.
Yes. Why do you say so? First thing.
So, first in PBF, we could find increased basophils as
Good.
well as the left shift.
Good.
Secondly, sir, platelets were increased, and in bone marrow aspirate as well as biopsy, megakaryocytes were increased.
Wonderful. What else?
The clusters were seen.
Great. Great. Right. So we think that is probably a myeloproliferative neoplasm, right? And also remember, in the history, the patient had some slight spleen, which was also palpable, right? So there is a splenomegaly. Elderly lady has a lot of hypercellularity. That is also a very important finding, that we have hypercellularity, we have increased megakaryocytes, and we also have some basophils in the peripheral blood. And these megakaryocytes do show some abnormal localization in the form of paratrabecular clustering, and we have some mildly 1+ kind of a retic. So now, what are the different myeloproliferative neoplasms that you know about, Bigrai?
Sir, CML,
Mm-hmm.
polycythemia vera,
Wonderful. Yes.
and essential thrombocythemia.
Great. ET and what is the one other major one that you're missing? Primary myelofibrosis, right?
Primary myelofibrosis.
Yes. So PV, ET, and PMF and CML are the most common ones, and we have some other rarer ones also, like chronic neutrophilic leukemia and eosinophilic leukemia, and now even the JMML is in the MPN category. But let's not go there. So first thing, of course, will be to rule out a CML. Do you think this looks like a CML? Chronic myeloid leukemia, Bikrai?
No, sir.
No. Why?
Because in CML, the myeloid series will be all the progenitor cell of the myeloid series will be increased.
Great.
In the PBF. Yeah.
Wonderful. So in the PBF only, we could not see the large number of myelocytes and metamyelocytes that we usually see in a CML case, right? That is one thing. And the other thing is also, you can see here in the differential that I gave, your erythroid precursors were around 21%. So the ME ratio here is around 3:1. In a CML, typically you'll have much lesser number of erythroids, and your ME ratio will be become much higher, like 8:1, 10:1, or even higher, right? So most likely not a CML, but again, for everything you have to rule out CML first. So we'll do a BCR-ABL and rule out CML. But before we go there, so we are thinking there is a PMF. Sorry, we are thinking this is an MPN, myeloproliferative neoplasm. And if you see, there's a wonderful table from WHO 2016 where different morphological features are used to differentiate between the three major non-CML myeloproliferative neoplasms, which is the PV, ET, and PMF. So you see the size of the megakaryocytes, their clustering, nuclear features, etc. So these you should go through this table. What is most important is that in ET, we'll have a lot of these large hyperlobated megakaryocytes, whereas in polycythemia vera, we have a lot of pleomorphism, and PMF, that is primary myelofibrosis, we have dysplastic, ugly-looking, bad-looking, hyperchromatic wale megakaryocytes, right? So that is there. Okay, so before we move in and try to figure out what is the final diagnosis, can you tell me, Dr. Ekta, what are the molecular differentials? What are the molecular abnormalities that we get in different MPNs? First of all, starting with CML in chronic myeloid leukemia.
The BCR-ABL.
Wonderful, we get a BCR-ABL there. Then now we coming to the non-CML MPNs, so PV, ET, and PMF.
So JAK2.
Great.
Mutation.
Great. What else? JAK2 is a JAK2 V617F mutation you're talking about. Great.
Yes,
what else?
JAK2 V617F. Yes, sir. And
anybody else? Bigrai?
JAK2 exon 12 mutation.
Right. That can also be seen in which one of these?
Polycythemia vera.
Wonderful, in polycythemia vera. And what else other than JAK2? Okay, so the driver mutations in MPNs are JAK2, MPL, and CALR, right? And JAK2 is present, as you can see, in nearly 98% of all polycythemia vera. So there is a major mutation that is present in polycythemia vera, whereas it's present around 55 to 60% in PMF and ET. CALR is the next most common mutation that is seen in both PMF and ET. And MPL is the third common mutation, right? So these are the three main mutations in non-CML MPNs. And then we have other mutations, which are the clonal driver mutations. And these are the various mutations that are seen in other myeloid neoplasms as well. Right. So now what do you think about, suppose we got JAK2 V617F positive in this case? It can still be PV, ET, and PMF. What would your DD be, Dr. Ekta? Your first differential?
So PV, if we will get JAK2.
But we also can get PV in ET and PMF, right?
Yes, sir.
So based on what are you saying, PV?
JAK2 mutation, but morphology like hyperlobated and hypo, we can think of ET more.
Great. Yes, pleomorphism, that is there. And also more things. Let's see. Let's go from the beginning. In the peripheral blood, we also have increased platelets, increased TLC, and slightly increased hemoglobin. So all increase in TLC is not something that is very common in ET, something that rules out ET almost, right? So that is one thing that is going not in favor of ET. So hemoglobin increased, platelet increased, and TLC. The so all three lineages increased. Pan-myelosis here increased in myeloid series cells, increased in erythroid series cells, and increase in megakaryocytes. And all of these are pointing probably towards the diagnosis of a polycythemia vera. So if you look at the diagnostic criteria of polycythemia vera, you will see that the elevated hemoglobin concentration is there. And how much is it? It's more than 16.5 gram per DL in men and more than 16 gram per DL in women. How much was the hemoglobin in this case?
15.6.
Right. So now will you be able to make a diagnosis of polycythemia vera in this case? Interesting question. Dr. Ekta, what do you think?
The mutation is there, and
Mutation is there, the morphological findings are there, all of that is there.
Yes,
So would you still be able to make it? One important finding that we probably overlooked and did not discuss too much, if you go back to the bone marrow peripheral blood, can you look at the MCV and the MCH here? How much is it?
The MCV is low.
Yes. What about MCH?
It's also MCV, MCH both are low.
Right. So now could you think of an explanation here? What are the conditions in which your MCV and MCH will be low?
Most common iron deficiency.
Wonderful, iron deficiency, right? And is iron deficiency common in India, especially in women?
Yes, sir.
It is very common in women, right?
Very common.
So this is something that happens a lot in our Indian, especially Indian females with polycythemia vera, that we don't get this cutoff of 16 and 16.5, and this is something which is called as a masked polycythemia vera, right? So although the cutoff is around 16 gram per DL in women and 16.5 in men, sometimes when all the other findings are matching and your hemoglobin level is not that much, just look if you have your MCV and MCH is lower, try and test for iron, and you'll frequently see that these are iron deficient patients of polycythemia vera, which is called as masked polycythemia vera in WHO, right? Okay, so let's move ahead and go from case 1 to case 2 now. So there is a 65-year-old female, has fever for 4 months with enlarged cervical and axillary lymph nodes. Liver is non-palpable. Again, spleen tip is palpable. And we go to the peripheral blood. And Dr. Ekta, can you tell me what your findings are here?
Sir, there is RBC population is little bit reduced, and we can see
just findings in general in the TLC, in the CBC. What is abnormal here?
Sir,
what about hemoglobin?
Hemoglobin is low, sir.
So anemia is there. What about platelets?
Anemia is there. Yes, sir. And sir, platelets are normal.
Right. What about TLC?
TLC is raised, sir.
Right. So you have anemia and mild leukocytosis, right?
Mild leukocytosis.
And
yes,
what
sir.
kind of leukocytosis is this? This is now, remember, a 65-year-old lady, and you see the differential count. What do you think it is?
So this is lymphocytic leukocytosis, 55%.
Absolutely. So there is lymphocytosis here, right? Right. So we talk about lymphocytosis. Lymphocytosis is usually more than 8,000 in young children and more than 4,000 in teenagers and adults. Of course, it is all age dependent. So you have this table from DACY where you have in different ages how much your lymphocyte should be, and you should define only based on that. Because if this count in a 1-year-old or 2-year-old child would be normal actually, right? So depending on the age, it's very important to see to whether to call it as lymphocytosis or not, right? So lymphocytosis can be primary, which is some lymphoid malignancies, or more commonly reactive, right? So next, I've given you some pictures here. So what do you think? What kind of lymphocytes do you see here, Ekta?
Yes, sir.
What kind of lymphocytes do you see here? Do these look as normal lymphocytes? What do you have here?
This one, it looks more of a reactive lymphocyte.
Okay, why do you say so? What do you commonly see in a reactive lymphocyte?
So more of reactive because so we can see there's nuclear grooving in this one.
Yes, absolutely. And I'm also showing this second one here. Now I'm drawing a circle around that. What about this?
We can see clear nuclear grooving in this one.
Right? Almost a cleft, through and through cleft is
Yeah,
there.
cleft. Yes,
Nuclear cleaving is there here. Right.
cleaving.
So
Yes,
do you think the nuclear cleaving is common in a reactive lymphocyte or a non-reactive neoplastic lymphocyte? What do you, the first question was, what do you commonly see in a reactive lymphocyte? How do you identify a reactive lymphocyte?
So we can see granulations in the cytoplasm can be also seen in a reactive lymphocytes.
More commonly
And
what?
yes, sir.
More commonly, what do you see in a reactive lymphocyte?
It's a little bit granular cytoplasm.
Okay, anything else? Jasleen, can you say any other quality of a reactive lymphocyte?
The reactive lymphocytes are a little larger with abundant cytoplasm, and you
Yes.
might also see nucleoli. Might also see
Okay,
nucleoli.
anything else? What about the cytoplasm? Other than being abundant, any color change?
Deeply basophilic will be.
Basophilic,
And
perfect, right? These reactive lymphocytes are reacting to some condition that is there in the body, and as a reaction, they are trying to produce a lot of proteins, right? So because of this production of proteins, what happens is that the nucleus becomes slightly opened up. Your nucleoli can also be seen because protein functioning activity is increased. That is why your cytoplasm becomes blue, because the blue cytoplasm has basically a lot of immunoglobulins that this nucleus is producing now, right? This cell is producing. So typically your reactive lymphocytes will be slightly larger in size and have slight blue abundant basophilic cytoplasm, right? So when we see a cleaved nucleus, Big Rai, what are your DDs when you see this kind of cleaved nucleus?
CLL can be.
Not very commonly. So if we see lymphocytosis with cleaved nucleoli, you can have some B lineage lymphomas like mantle cell and follicular. In some T cell lymphomas like mycosis fungoides and ATLL, and sometimes also, just remember, you can't really rule out reactive causes, because especially pertussis and chronic smoking patients can have these kind of cleaved nuclei as well, right? So at the moment, we are probably looking at a non-clonal or a clonal clause, but we can't really be sure. Okay, so we go on to the bone marrow with the bone marrow aspirate. Dr. Ekta, what do you see in the bone marrow aspirate?
A lot of smudged cells are also seen.
What are these cells? The ones that I'm... These are all tiny lymphocytes, right? A lot of lymphocytes are there in the bone marrow aspirate. So number of lymphocytes are definitely increased in the bone marrow aspirate as well. Okay? And then we go to the bone marrow biopsy. Now, Dr. Ekta, can you describe this biopsy? What do you see here?
Yes, sir. This is a the intratrabecular spaces. We can see a lot of fat.
Right. So this is a 65-year-old lady. You'll expect a lot of fat here, right? You'll expect
Yes,
around
sir.
60% kind of fat in this patient and 30 to 40% cellularity, right? So does
Yes,
this
sir.
look, what is the cellularity here? Do you think this is normal cellular or hypercellular for age?
So for age, hypercellular, no.
Hyper, right?
Hyper,
Because
yes,
this
sir.
looks more, what is the cellularity I think here? What is the cellularity here in this case?
So 70%,
60-70% clearly, at
60 to
least, right?
70%.
Yeah,
Yes,
absolutely.
sir.
I agree. So definitely hypercellular for age. And let's go closer. And these are the images I've given you. What do you see here now? Anybody else? Dr. Jasleen?
increased lymphocytes,
Right, they're increased, absolutely.
facial excess of lymphocytes.
Any particular region in which they are increased?
Within
Paratrabecular
area.
Absolutely, right. So even here you can see there are these areas where around the trabeculae you can see a lot of lymphocytes, right? And in the next slide is very, very clear that you can see this bony trabeculae, and along the bed of the bony trabeculae you have a lot of these lymphocytes. So this is definitely a paratrabecular kind of a bone lymphocytosis that is there in the bone marrow biopsy. Another picture showing just the same. This is your paratrabecular, but you can also see that there are these interstitial nodules also. So we have paratrabecular as well as interstitial nodules. So when we see paratrabecular lymphoid aggregates, do you think that is favoring more of a reactive or a neoplastic? Big Rai? Big Rai, can you hear me?
Sir, yes, sir.
Yeah.
So neoplastic.
Neoplastic more, right? So we can have different kinds of bone marrow infiltration. This is a beautiful picture that is taken from Barbara Bain, Bone Marrow Pathology. Do read this book. It's a beautifully written book. And the different kind of infiltration that can be there are interstitial infiltration that you see here, and some nodules that you see here, and this is a paratrabecular. So out of these, the paratrabecular one is much more commonly seen in neoplastic lymphoid infiltrations, that is lymphoma infiltration, rather than a reactive cause. Interstitial, nodular, etc. can all be seen in reactive lymphoid proliferations also. This looks more like a neoplastic at the moment. And if you see paratrabecular, much more common in follicular lymphoma compared to everything else. Okay, so it looks like probably a lymphoma infiltration. When you see this kind of paratrabecular infiltration, you start thinking of follicular lymphoma. But how do we confirm it, right? So we think about this, we do an IHC. What do you see here, Big Rai? What do you see here? We have done a CD3 and CD20 only.
CD20, yes.
So do you think this
So
is CD20 brighter or CD3 more? T cell lymphoma or B cell lymphoma?
So B cell lymphoma.
Right, this looks like a B cell lymphoma because the nice paratrabecular CD20 positivity is there. We also have these T cells which are positive, but these are the background reactive T cells that will always be present in these lymphoma infiltrations. But this kind of B cell dense positivity, this is not normal for a bone marrow. This is definitely increased. So this looks like a B cell lymphoma for us. So to make a diagnosis of a bone marrow infiltration by a lymphoproliferative disorder, we have to look at clinical behavior, we have to look at morphology. The morphology is slightly pointing towards follicular lymphoma because of the infiltration pattern and also the cleaved nuclei, and then immunophenotype, right? So immunophenotype, we have done only IHC here at the moment. How else can we do immunophenotyping, Dr. Ekta?
So flow cytometry.
Flow cytometry, perfect. We have to do flow cytometry. And so let's do flow cytometry for this case. And this is what is there. We are getting a CD19 positive cluster. So we have around 16.1% of CD19 positive cells, which is very, very high, right? Normally your CD19 positive cells should be less than 4 to 5% of all the bone marrow cells. So this is high, definitely increased. These are nicely positive for both CD20 and CD79B. You can see this, both CD20 and 79B positive. And what do you see in this figure, Dr. Ekta? What do you see in this figure, the one that I'm taking right now?
So CD10.
Right. Is it positive for CD10 and CD5?
CD10.
CD5 negative, right? These are your normal T cells, which are CD5 positive, but your blue B cells, 19 positive cells, are CD10 positive. And what do you see in this flow plot?
So kappa.
So these are all kappa positive and not showing any lambda, right? So these are kappa light chain restricted. So these are clonal B cells, which are CD10 positive. So based on flow cytometry, how do you classify your B cell lymphomas? Ekta? This is something very important. We have to know this. Just lean. What are the two main markers which we use for classifying B cell lymphomas?
Sir, CD5 and CD23.
5 and 23.
No, the 23 is later. 5 is one of them. What is the other one? So first we'll have to say whether it is the B cell or not using CD19 and CD20, right? That will tell us the lineage. That is a B cell lineage. And then further we divide them on the basis of two markers, CD5 and CD10. So there are 4 types of lymphomas, the 5 positive lymphomas, which are basically CLL and mantle cell, and the 23 that we are talking about helps here. Your CLL is positive for 23, whereas mantle cell is negative for 23. A better marker now is CD200. The second kind of lymphoma is CD5 negative but 10 positive, right? And then we have the dual negative ones and the very rare dual positive ones. So when you have a 5 positive and 10 negative, we think of CLL and mantle, right? When we have a 5 negative and 10 positive, so that is what we have in our case. So when we have a 10 positive and 5 negative, we have follicular lymphoma, DLBCLs, Burkitt's, and sometimes the rare B lymphoblastic lymphomas, and the 5 and 10 dual negatives are the hairy cell leukemia, marginal zone lymphoma, and LPLs. So we are in this category at the moment, 5 negative and 10 positive. And what do you think our diagnosis is? Based on everything, based on morphology, based on the infiltration pattern, and now based on flow cytometry, what do you think our diagnosis is? Big right?
Follicular lymphoma, sir.
Follicular lymphoma, right? Absolutely. So we are now slowly looking at first morphology of the peripheral blood, and then the bone marrow aspirate, and then the bone marrow biopsy, then doing an IHC, and finally doing a flow cytometry. We have reached the diagnosis of a follicular lymphoma that is there in the bone marrow infiltration. Great. So do remember this chart. This is something that is very important. 5 and 10 will be used to classify our mature B-cell neoplasms, right? So great, we finished this. We go to our case 3. So case 3 is a 28-year-old male, has fever and shortness of breath for 1 week. This is quick. Let's quickly do this. Mild hepatosplenomegaly and cervical lymph nodes are enlarged. Big Rai, what do you see here in the peripheral blood? Anything of interest in this? How much is the hemoglobin?
The hemoglobin is reduced.
It is mildly reduced, right? 9.8.
Mildly reduced, yeah.
Yes. What about platelets?
Platelet is normal.
Great. What about TLC?
TLC is also reduced.
Right. So the most important finding probably here is this, right? We have a leukopenia here, definitely, and some amount of anemia, so bicytopenia, but more focusing towards the leukopenia. So do you think this patient should be undergoing a bone marrow examination? Is this an indication for a bone marrow examination? Or would you want to give a diagnosis here itself? Big right?
Yes, sir. We'll go for bone marrow examination.
We have to, right? We have a young male who has fever and shortness for 1 week, and some lymph nodes and hepatosplenomegaly as well. And we have a leukopenia. So this can't be explained. The cells that we're seeing here, they look like normal lymphocytes only, right? These look like lymphocytes. So there is definitely a lymphocytic prominence, but the TLC is very low. So probably the patient has a lot of neutropenia that is happening, right? That is a finding that we have here in the peripheral blood. There is neutropenia and there is leukopenia, and there is also mild anemia. So we go to the bone marrow aspirate. What do you see here, Big Rai, in the bone marrow aspirate?
So I can see hand mirror type of cell.
What type of hand mirror type of cell? Okay, okay. Let's go closer and let me ask Ekta. Ekta, what do you see now? There's the higher power view, oil immersion. What do you see here?
You can see blasts.
Do you think they're blasts? Why do you think they're blasts?
The prominent nuclei, irregular nuclear membrane.
Right. What else? What about the chromatin?
And
Fine chromatin.
and the fine and the in cytoplasm we can see this or rods.
Right. Beautiful. Right. So you can see. Let me draw one cell here. So you can see this cell here.
Yes, sir.
It has a beautiful OR rod in the cytoplasm, right? But also, as Big Rai was saying, we also have these cells, right, which have hand mirror-like appearance, right? So where do you typically see hand mirror-like appearance?
Typically, we can see in ALL.
ALL, right? More commonly in ALL. But where do you see OR rods now?
AML.
AML.
So how do you? So now you think this is the acute leukemia. How do you classify acute leukemias, Jasleen?
Acute leukemias are classified, there are differentiation according to genetic or by differentiation. By differentiation, we have undifferentiated with minimal differentiation or with.
So this you're talking about AMLs, right? But before that, what do you have to do first?
Sir, acute leukemias can be divided into AML or ALL with the help of MPO or PAC stain.
Great. So MPO staining or PA staining is something that you will do. And how does it help? How does MPO help?
Sir, MPO will be positive in acute myeloid leukemia.
Great. Is there any acute myeloid leukemia which can be MPO negative also?
The undifferentiated one and
yes,
one.
right? M0 or the AML without differentiation is MPO negative, less than 3%. Any other AML which can be MPO negative? Big Rai or Ekta, anybody? So the monocytic leukemias or the erythroid leukemias or the megakaryocytic leukemias, right? These are all kinds of acute myeloid leukemias which can be MPO negative as well, right? So MPO is a very good stain to say whether it is positive or it's an AML or not, but it can be negative. So I think I've given you an MPO stain here. What do you think this is, Jasleen? Is it MPO positive or negative?
So negative.
Everybody agrees? Big Rai?
So, positive.
Positive. What about Ekta?
Positive.
Positive,
So
right? So you can
positive.
see these
Yes.
beautiful blasts which are MPO
Yes.
positive here, right? Also, you can see these beautiful or rods sticking out,
Yeah.
and or rods are also positive. So this is nice MPO positivity. Definitely more than 3% of these blasts are MPO positive. Even these blasts here are showing MPO positivity, so there's an MPO positive. So do you want to call this an AML right now, or do you want to do something else? Is cytochemistry of MPO and PS enough to classify your AMLs into myeloid and lymphoid? Or do you also have another category and you want to do some other technique as well?
Go for
So we can go
genetic
for flow
analysis.
cytometry.
Wonderful. So let's go for flow cytometry, and that has now become a technique of choice for diagnosing acute leukemias. Definitely, we have to do an MPO initially, but also we have to do a flow cytometry to make a final diagnosis of an acute leukemia these days, right? So this is the flow cytometry plot that I give. Before we go here, Jasleen, Big Rai, and Ekta, do you have flow? Any of you have flow in your centers?
No, sir.
Not really, right? Okay, so let's easily take it easy. So let's see what you have here. Can anybody explain? Ekta, can you explain these plots? What do you see in the first plot here?
So in first plot, we can see CD45 positivity.
Right. And do you want
And
to call them CD45 positive only or something else? So if you look at this plot, this is the most important plot to begin with. This is CD45 versus side scatter. And you see a cluster of cell here, which I'm marking right now. You see this? These are basically lymphocytes. Lymphocytes have a very good CD45 positivity and they have a low side scatter, right? And these cells that we have already gated here, the precursors, the one which we have given red color, is there 45 lower in intensity compared to these? It's lower than these, right?
Yes, sir.
So definitely lower than this. So we'll call them as dim CD45. And decreased CD45 expression compared to lymphocytes is a property of the blasts. Sorry. Immature cells have decreased CD45. So these cells, which are CD45 dim and have a low side scatter, these are the precursor cells or the blasts, which are nearly 81% of all viable cells. Okay, Jasleen, Big Rai, Ekta, all understood this?
Yes, sir.
Right.
Yes.
So this is how we gate our blasts. We first identify our lymphocytes, see where our lymphocytes are, and the other population, which is if it is dimmer than that, then it becomes blasts. And then we gate them. That is, we give them one color, that is red color, and then other plots we start seeing the red color. So now let's follow the red color in the other plots. Do you think it is 19 and 10 positive or negative?
Negative, sir.
Negative, है ना? This is some 19 positive, maybe normal B cells. This is some 10 positive, maybe granulocytes. So these are 19 and 10 dual negative. So probably not B lineage cells. What about 33 and 117?
Both are positive, sir.
Good. So this is what kind of lineage? 33 and 117 is lineage. Which lineage?
Myeloid.
Myeloid lineage. Wonderful.
Myeloid.
So at the moment we have some myeloid lineage markers, and this is also 34 positive and HLA-D are variably positive. You agree?
Yes.
So we have 45 dim and 34 positivity, which is telling you that these are immature cells, that these are blasts. And at the moment, we have negativity for 19 and 10, so probably not B cells. Positivity for 33 and 117, so probably myeloid series cells. And now what do you see here? CD7?
CD7 positive.
Positive, right? So these are normal T cells, which are CD7 and surface CD3 both positive. These are our abnormal blasts, which are positive for CD7 but negative for surface CD3. Are they positive for 2 as well?
Yes, sir.
They're positive for 2 as well, but negative for 5. And do you think they're positive for cyto CD3 as well?
Yes.
Yes. What about MPO? MPO is already positive in the
MPO
cytochemistry.
positive.
Here also it is positive. So now what is your diagnosis? We have we don't have B lineage markers in these blasts. We have myeloid lineage markers, including MPO, and we have T lineage markers, including cyto-CD3. So what is your diagnosis now?
AML.
Anything else? So more than AML or ALL, is there a third kind of acute leukemia?
MPAL, mixed lineage.
MPAL, wonderful, right? So it's a mixed phenotype acute leukemia. So I kept this case just to highlight how important flow cytometry has become now in the diagnosis of acute leukemias, that even though you might have nice OR-ROD positivity as well as MPO positivity, but if you remember Big Rice's description, initially only he saw those hand mirror-like cells, which is more pointing towards the lymphocytic lineage. So this flow cytometry will tell you exact lineage of these cells, and since we have MPO positivity as well as cyto-CD3 positivity, this becomes a mixed phenotype acute leukemia, right? So this is the table that you have. Mixed phenotype acute leukemias can be with PCR, ABL, or KMT2A rearranged, and some other defined alterations are also there. And otherwise, they can be called as B myeloid or T myeloid. We have also seen BT and myeloid lineages mixed together, but this becomes the mixed phenotype acute leukemia, T myeloid, right? And then we go through the lineages. Specific for T is cytoplasmic or surface CD3. Cytoplasmic is much more common. Surface CD3 coming positive in an acute leukemia. T, ALL is not very common. It's pretty rare, but cytoplasmic CD3 will definitely come. 19 strong with 10, 20 or 79A will make it a B lineage, but we did not have 19 positivity, and MPO positivity is there, so it is a myeloid lineage is there. So we have myeloid lineage and we have T lineage, so it becomes the mixed phenotype acute leukemia, T myeloid. Okay? Right. So we move on to the next case, which is case 4. Let's go to Ekta. We have a 4-month-old girl, has progressive pallor since birth and received 5 units of packed RBC transfusion till date. So very young 4-month-old infant already receiving transfusions. And this is the peripheral blood picture that you get. So Ekta, can you tell me, do you find anything abnormal in this peripheral blood?
Yes, sir. Hemoglobin is very low.
Very good. Hemoglobin
And
is very low, which is commensurate with whatever we had here, right? Progressive pallor
yes, sir.
and receiving transfusions. Anything else?
And sir, the platelet is normal,
Good. Very
and
good. TLC.
TLC is also normal, or
Yes,
sir.
this will be normal for a
Normal.
4-month-old. Absolutely, you're right. So
Normal.
platelets are normal, TLC normal. What about the differential counts?
The differential is also normal for a 4-month.
Wonderful. At the moment, we only looks like we have hemoglobin which is low. Anything else that is there in this slide that you think is abnormal? What about this here? You have chosen not to read this.
Retic.
Yes.
Count is decreased.
It is decreased, right? So at the
Yes,
moment
sir.
we are seeing that there is reduced decrease. So how does retic count help in cases of anemia, Big Rai?
It
Or
helps us
Ekta,
differentiating between hemolytic and iron deficient other anemias if it's raised in hemolytic anemias.
Great. So basically, you can say the anemias can be divided based on retic as hyperproliferative or hypoproliferative anemias.
Yes.
Hyperproliferative anemias are the ones which are typically in which, as a reaction to the anemia that is there, the bone marrow starts producing more and more of erythroid precursors, and so you'll have increased reticulocytes.
Increased retic count.
Right, and then there are the hypoplastic or hypoproliferative anemias where the bone marrow is not able to produce that many erythroid precursors in the first place. So your retic count there will be low, right? So it looks like it's a hypoproliferative kind of an anemia. Right. Then we go to the bone marrow aspirate, or this is actually the imprint smear. So here, Jasleen, can you tell me what are the findings in this?
Sir, the cellularity seems fine.
Difficult to comment in one section, but okay. Cellularity, what do you think?
Cellularity seems okay, sir.
It seems okay. Okay, then what else?
I can only see myeloid series of cells, erythroid series.
What is this? On the tick right now?
Mega-karyocytes.
So megs are also there, right? Absolutely. So megs are there, the myeloids are there, but you can hardly see any erythroids, right? That is the major finding here. The erythroids are hardly noted here. There's another picture here. Ekta, can you tell me what are these cells that I'm marking right now?
Plasma cells.
So do you think in a 4-month-old baby, plasma cells should be there? What else can be these? Jasleen or Bigrai, anybody?
It can be osteoblast.
These are osteoblasts, right? So you can see the difference between osteoblasts. First thing is you can look at the nucleus. The nucleus does not show any clock face, right? And although both have eccentrically placed nuclei, but here it is almost coming out of the cytoplasm. So it is a pouting nucleus and it is in groups. And you have more than a perinuclear halo, it's a paranuclear halo away from the nucleus, right? So, and they're also in groups. So this is basically an osteoblast cluster that is there. Right. So, but again, in this picture also, what we see is most of these cells that you are seeing here in this region, most of them are myeloid series cells. Hardly seeing any erythroids. Maybe one, maybe this cell that I'm circling right now could be an early erythroid, but very, very low. So your ME ratio will be very high. Right. So that is exactly what you see in the biopsy as well. Bigrai, can you tell me what you're seeing in the biopsy?
Yes, sir.
What do you see?
The cells of erythrocytes are decreased actually, sir.
Yes, that's what it is. What about cellularity?
Cellularity seems to be normal.
Seems to be normal. We are seeing some fat spaces here. You can see some very few fat spaces, but 4 months may it could have been even lesser fat space. We are almost expecting no fat space at all, but still take it. There's more or less a normal cellular kind of a bone marrow. But again, what is most important is that we don't have too many erythroids at all here. Right. So now, Bigrai, what do you think we are looking at? What is your diagnosis here, or what are your DDs?
Can it be a pure red cell aplasia?
This definitely looks like a pure red cell aplasia, right? This is how we define pure red cell aplasias. In pure red cell aplasias, we don't have enough erythroid precursors in the bone marrow, and in the peripheral blood, we have reduced reticulocyte count, right? We have both of these here in this case. So this is definitely a pure red cell aplasia. What now? Can we further go ahead and what special type of PRCA is this now? This now, remember, a 4-month-old.
Yeah. So
Congenital, right? This looks
Congenital.
like a congenital pure red cell aplasia. Absolutely wonderful. So this looks like a congenital pure red cell aplasia. Why? Because it is a 4-month-old baby. 4-month-old baby, right? Very, very early. Okay. So how do you further go ahead? This is how we classify pure red cell aplasias. They can be congenital pure red cell aplasia, which is basically the DBA or the diamond-Blackfan anemia. And then we have a lot of acquired ones. In the acquired ones, you have infections being the most common, right? Parvovirus B19 infection, I think all of you know this. Parvovirus B19 infection is the most common cause of secondary pure red cell aplasia. Then we also have some lymphoproliferative disorders. Always remember CLL, LGL leukemias. These are commonly associated with PRCA, especially LGL leukemia. And also in the solid tumors, we have thymomas, right? But there's also a small baby. So remember that this can also come in the picture. This, which is called as the transient erythroblastopenia of childhood. This usually happens somewhat later, not at 4 months of age. Usually, slightly older children it's much more common, where you have transiently erythroblastopenia, just like gives a PRCA-like picture, but usually resolves on its own, right? So next, what is the genetics of PRCA? In genetics, can anybody tell me what is the genetics of PRCA in Diamond-Blackfan anemia? What do you see there? What are these genes? So you can see most commonly mutated gene is which one? The one that I'm taking here. What is this?
RPS19.
RPS19 is the most commonly. What kind of gene is this? What is RPS? So it's a ribosomal protein, right? These are all, you can see RPS19, RPL5, RPS26, RPL11. These are all ribosomal proteins. And so there is deficiency in the ribosomal proteins in these patients of Diamond-Blackfan anemia. And that is why they have anemia. So this is basically called as ribosomopathies. So there's a group of disorders called as ribosomopathies in which the ribosomal proteins are abnormal, mainly because of some mutations there. And what do ribosomes do? Ribosomes are, they help in protein synthesis, right? In translation, they help in protein synthesis. And in the bone marrow, we have lineages of the megakaryocytes, we have lineages of the granulocytes and the erythroids, right? Which of them are the ones which are produced at the maximum numbers out of erythroids, megakaryocytes, and granulocytes? The turnover of the erythroids is the highest, right? We have the number of erythroids is so much more compared to your platelets as well as your leukocytes, right? So that is why all our ribosomopathies will affect your erythroid lineage first before it goes on to affect the other And if you want to know a connection here, you know MDS with deletion 5q, that is a special type of MDS that also has pure red cell aplasia as one of the findings, because there also a ribosomal protein RPS14 is affected. So this is the connection that you get among all ribosomopathies, right? Transient erythroblastopenia of childhood we have already discussed. But so I think we can finish here, quickly go through the last case. Ekta, can you tell me about the last case? We have a 42-year-old lady diagnosed with CKD and complaints of shortness of breath and fatigue, and on examination severe pallor, no organomegaly or lymphadenopathy. So what do you see here, Ekta?
So we can see here low hemoglobin, raised retic count, platelet is normal, and TLC is towards the lower limit.
Right.
Or
So we are
reduced.
almost having only anemia kind of a picture, right?
Yes, sir.
And
Yes, sir.
reticulocyte percentage 2.9%. Do you think is normal or high? Do you want to correct this? Is there any way of correcting reticulocyte percentage?
Yes, sir. We can do corrected retic count.
Why do you want to correct it?
Sir, low hemoglobin.
Because of anemia. Yes,
Yes,
because
sir.
of anemia, there is
Anemia.
already a increased production. So we have to compensate for that. And if you compensate that, if you do a correction, it will probably come in the normal range only, right? It is 2.5,
Yes,
it will
sir.
probably come somewhere around 2.1 or 2.0, right? So most likely, it is not a hyperproliferative, normoproliferative kind of an anemia is there, right? We go to the
Yes,
bone
sir.
marrow biopsy figure. What do you see here, Ekta?
Sir, it's looking, sir, cellularity is low for age.
The age was 42, maybe slightly low. You're absolutely right. Okay, what else?
Yes, sir.
Anything else?
And so these trabecules are very widened.
Very good. So when you're looking
Fibrosis.
at the bone marrow biopsy, you
Yes,
don't
sir.
just look at the intratrabecular space, you also look at the bone marrow, the bone, the health of the bone, right? Good.
Yes, sir.
Let's go into a higher picture. Let's bring in Jasleen here. Jasleen, what do you see here now in this two pictures? Jasleen, are you there?
Hi, sir.
हाँ जी बताइए.
So paratrabecular fibrosis.
Wonderful, right? So this is what you're seeing here. This is a very good example of paratrabecular fibrosis. And what else?
I can osteoclasts are seen.
Right? These are the osteoclasts you can
Okay.
see here, right? Great, great. Big Rai, anything else? What is this that is happening here?
Scalloping of the trabeculae.
So tunneling basically, right? So the osteoclasts are eating up and we are getting a tunnel inside this. Here also you can see these two osteoclasts probably eating up here and some prominent osteoblastic lining. This is osteoblastic lining which has become very prominent. So all of these are features of what, Big Rai? So what was the history? Try and correlate. The history was the patient who had a diagnosis of
CKD stage 5.
Yes, CKD stage 5. So in CKD stage 5, you have an anemia, which looks like a normoproliferative anemia, no TLC increased or decreased, platelets normal, differentials normal, you have thickened bony trabeculae, and you have these findings, you have osteoclast increase, paratrabecular fibrosis, tunneling. So what do you think this is?
Renal osteodystrophy.
Right, renal osteodystrophy is probably the best answer that we have, and most renal osteodystrophy patients will have some bony changes as a combination of secondary hyperparathyroidism. That is what we are seeing here, hyperparathyroidism related changes, especially the paratrabecular fibrosis and the tunneling that is there. We can also have osteomalacia and osteosclerosis in this, right? So do keep this in mind. This is a very important slide. You can get exam slides for this. CKD patients may, if you do a bone marrow for persistent anemia, a lot of times you'll find this. As I think Ekta initially noted, we also had low cellularity. So when the CKD progresses, eventually fibrosis will lead into low cellularity as well. So there's probably a slightly advanced case of CKD and renal sclerosis. But something that I did not show you in this, and there was a surprise for us in this case as well. So when you look at renal dystrophy cases, sometimes you can get the cause of the renal abnormality, the CKD, in your bone marrow itself, and that is something that we had here. Can you notice, all three of you, what is this? What are these findings here? Can you see these things? Jasleen, can you see what these are?
Crystals?
Sorry, can you be louder?
Are they crystals?
Absolutely beautiful, right? They're crystals. And what kind of crystals? You can see here again. There's also one, and they're beautifully arranged almost in a flower-like pattern, right? And we did plain polarized microscopy. And what do you see in polarization? These are beautifully shining in polarized light, right?
Uric acid crystals.
These are oxalate crystals. Sometimes you get these oxalate crystals in the bone marrow biopsy itself, and you can diagnose it using this plain polarized microscopy. And this is the oxalosis that was there in this patient, which led to the CKD of this patient. And that is why the renal osteodystrophy happened as well later, right? So when you look deep inside, you can get answers that you're not even searching for, right? I think we can stop here. There are deposits of oxalate crystals that are there, oxalosis, and all the best to you guys. Thank you.
Thank you, sir.
Thank you so much, sir, for covering all the important exam cases from morphology to the molecular level. Thank you so much, Charanjit ma'am, also.
Yeah.
Sir, there was active participation in the chat box throughout the session. We don't
Sorry, I was
have
not
any
looking at that.
questions as of now.
Okay, do we have any questions?
No, sir.
Right. If not, then I think we had a great session. Thank you all,
Yes,
participants.
we had a great interactive session. Thank you so much, ma'am, Charanjit ma'am, and sir.
Ma'am, I think there is one question here.
Yes, yes.
Sir, do we look for pan-myelosis in CBC or bone marrow?
Pan-myelosis is actually a finding of the bone marrow biopsy, right? It's a finding where all three lineages are expanded in the bone marrow biopsy. This is something that we very frequently see in all MPNs, but especially in PV. What you have to remember in PV is that, you know, when we look at the bone marrow biopsy, we have the cortical bone, and then we go into the medullary bone where we have all the bony trabeculae, right? The subcortical marrow spaces, first 2 or 3 marrow spaces, are usually very hypocellular. You don't have too many marrow elements there. This is normal, this is physiological. But in a polycythemia vera or other MPNs, even those marrow spaces, the subcortical ones, they will also get filled up by the myeloid series cells, erythroid series cells, and megakaryocytes. So you'll not really have any physiologically hypocellular subcortical marrow space there at all. So pan-myelosis means the entire bone marrow will be filled by all three lineages, and also the cells will go in those areas where there are normally no cells at all.
Okay, thank you, sir.
So there is one more question. What is surface CD3? What is the significance?
So I think we discussed this. Surface CD3 is the marker of a mature T lymphocyte, and usually in T ALLs we don't get surface CD3 positive. We get cytoplasmic CD3 positive. There are some rare T ALLs. So when we look at classification of T ALLs, we usually recapitulate how they are maturing in the thymus. So we have pre-T, pro-T, then cortical T, and medullary T. So by the time they reach the early T ones, the pre-T and the pro-T, they are negative for surface CD3 and then negative for CD4 and CD8 as well. But they're always positive for cytoplasmic CD3. By the time they reach cortical stage, they become positive for both CD4 and CD8. And then after that, rare TALLs become the medullary TALLs, where they are either CD4 positive or CD8 positive. In this stage, sometimes you can have surface CD3 positive also, but less than 5% of TALLs will have surface CD3 positive. There will be cyto CD3 positive, but not surface.
Thank you, sir. So there was one more question. In case of MPAL, if CD3 was negative, how we should have interpreted the CD7 and CD2 in this case? Could it be autofluorescence from myeloblast?
It is so autofluorescence is something that you'll have to set in your lab. You have to see that your cells are not showing usually. So the blasts in ALLs usually will not show, or other AMLs also will not usually show autofluorescence. It is usually only APMLs which go ahead and show autofluorescence. So the CD3, CD2, and CD7 in this case looked absolutely genuine. And if we did not have a cyto CD3 positivity here, we would have called it as an AML with aberrant expression of CD7 and CD2. Aberrant CD7 is very, very common, not uncommon at all, but also CD2 can sometimes aberrantly be expressed in AMLs.
Thank you, sir. We don't have any more active questions, new questions.